Our next speaker will be Cristobal Passalacqua. Did I pronounce that right? All right. From SwanBio with an update on Propel.
Well, thank you so much, and to the organizer, and more important for all of you. And the energy in this meeting is amazing. And it's 5 p.m. and we're still here. They are answering questions. So shout out for all of you that you are here. Thank you so much. As you know, I'm work for SwanBio. I'm a clinical geneticist. I see patients with different diseases, and S-linked disease is unfortunate. They always quote like this kind of male disease, and I'm really apologizing on behalf that we're going to present mostly focus on male, but we really understand the struggle of the female community, and that is something that we keep in really in the front of our mind that we need to address. Thanks. So SwanBio is a small company based on the need that we need to address an issue that, as we know, is frequent. It's a rare disease, but it's more frequent than we hope to be. And it's founded in 2018 by one of our members here, Florian Eiler. We have the patient advocacy community that was since the beginning really close to us. We saw a need that we need to do something. And the technology, as we saw through the day, is evolving, and AAV therapy seems to be a potential right candidate to tackle the disease. Again, we're not seeing the one therapy will go and cure it all. One therapy will be effective for everybody, and the cooperation between all the industry and all the science will make this happen. Why AAV is an option? As we discussed previously, and we see the evolution in technology, different capsids, we call it like this kind of transporter, or like, for example, an Amazon driver, that you have something that need to go to a specific place. And AAVs is the associated adenoviruses. They are viruses that are all around us. They are non-pathogenic, meaning that don't produce disease, but they're really good in transport and go when they need to want to go. In this case, there are different serotypes or different, or like cars or model of transport. And AAV9 is really good to go to the nervous system. So other therapies using for the liver, other for the heart, we are using AAV9 to go to the CNS. And in that regard, AAV9 is really good. What we carry inside depends. And in our case, it's the gene of ABCD1. The goal is to transport a normal copy or an effective copy, and hopefully replace something that is defective. It's important that the capsid itself don't produce a disease, and people get concerned when you get something in your body, and in this case, we're talking about millions of viruses. So of course, it's gonna be a concern, people, how I get this into my body. This is important, and it's only the shell. There's no information to reproduce or multiply the virus inside. That also, as we saw in the lentivirus therapy, can be with a downside. These are not going to multiply. So all the copies that we're putting there is the copies that we're going to have at this moment. Their cells are not going to replicate. And more important, we use a promoter, meaning we give them orders to the cell to start producing this protein. In our case, ABCD1. This not go to the center of the DNA, doesn't integrate most probably, and I want to highlight that there's been cases in the literature in animal model that potentially can be integration. So we're not saying that AAV is 100% safe, and I want to say it up front because this is an ever-evolving technology. But the most important, we're producing a healthy copy of ABCD1. AAV therapies is not that new, it's new-ish, and now there are therapies approved in the United States using AAV. There are different serotypes and different diseases, as you can see, and we update this slide all the time because thankfully there have been new approved therapies. In this case, this year, there have been 2 therapies for 2 different diseases, and the learning experience is so important. As we said, we all learn from each other. So the safety profile of one can help the others. And also the regulators are learning how we can assess this safety profile, meaning that if we evaluate, for example, for 5 years, maybe we need 10, or something that they saw in one patient, in one disease, and then they saw it in another with a different disease, maybe it's related to AAV. If they don't saw it, maybe it wasn't. So this is a learning curve, not only in this case, for example, for AAV9 or only for AMN. It's a collective learning, and that's why we encourage everybody and investigators to publish the data. And us as a company, we have the mandate to also publish and communicate what we are learning for safety, but also efficacy. In this case, returning to AMN, we decide that AAV9 will be a right candidate to go directly to the place that we need to have in the spine. And you can do it in different ways. Normally use it as an IV infusion and go to bloodstream, AAV9 cross the blood-brain barrier, so we'll go there. The issue though is the doses. And as we've seen in other techniques and in other diseases, you need to put billions or trillions of viruses, and not all of them, they're gonna cross the blood-brain barrier. If you do, in this case, intrathecally, you have all that concentration in just one spot. So overall, the doses, meaning how many viruses you need to use, can be a lot smaller. So hence your ratio is a lot safer, potentially. So I want to say that this is all based on animal data, and we're just starting the studies in humans, and Dr. Hayward will give that experience. So take this with a grain of salt, that this is based on animal data, and the rationale that use a concentrate doses where you want to have the action, the safety profile will be better than all around the body, and then just a percentage go to the spine. Our company understand the struggle of the disease, and as we hear today, natural history is fundamental. Not everybody progresses in the same way. Men are different, women how to progress the disease. Even between men, the progression of the disease is different. If we don't understand in a ground sense how the disease progresses, it will be really hard to see in 6 months, 1 year, 2 years, how the disease progresses in a therapy. So that is really important for us. Natural history studies have been done, and we're learning from them. But when we talk with regulators, they said, well, something do 10 years ago is not the same. There are different therapies, there are different indications, quality of life change. So we need to have something that is really happening right now that we can compare. And also, we want to do it as similar as possible, that the natural history be as similar as our active control study, because then the apple to apple can be seen easier, and hopefully when we develop in further stage of the program, you can use that natural history study to compare as a progression. At the same time, people around the world are participating in the study and how they progress versus people entering the study, and if we see differences. How we see in the slide, there's also, we understand the burden. We hear people here traveling all over the world, going to places to see this great doctor that have the knowledge of AMN, and that is really challenging. So for that reason, we try to do it half and half, or even 3/3, 1/3, that remote visit, and how valuable is this? We can do some measurement to video conference, to wearables, and how we can get that knowledge and then discuss with regulators. Then we can do the same than we do it in the clinics, but at home. Dr. Hayward is gonna talk more about this, but unfortunately, we cannot invite everybody to participate. We need to have a narrow vision first, and from there, we can expand to invite more people. And that is really important, what we're doing today. That doesn't mean in the future, we're gonna invite more people, for example, with more severe disease, or non-affected yet, but they have the mutation, or for example, females. We really understand the struggle, and we really want to be part of the solution. I'm happy to announce that the current signet is complete enrollment. We have 65 great persons that are participate, and we have for most of them, 1 year follow-up, but we're continue collecting data. And this is really important because, again, it's in real time. There are people doing this analysis, performing at home, going to the visit with the doctors. And with that data, we can collect the information and have a better understanding how we can do a better clinical study. And as I mentioned, the wearables, we have 2 in this study. One is the look like a watch, the active watch, and that is same as your watch, measuring calories, activity, time of sleep, time of wake. But also we have another that is the Opal sensor. Then, as we saw in another presentation, we see a more sophisticated measurement. For example, balance, how you sway, and that is really important because we need to discuss with regulator that you don't need to go to the office to a doctor every 3 months. Maybe you can do it just once a year, and the rest of the visit can be at home, and we can get that data from the computer and show that we can see a more detailed correlation. And then the other studies, we can do it more flexible with the patients. And here we can see early data comparing the remote visit versus in-person visit. And we see that there is still some tune that need to be done. Not all the time we see a one-to-one correlation, but nonetheless, some endpoints are better than others. And that is really important for us because we know the struggle that people progress in different ways. And also, it's hard to reproduce in a short period of time how they're going to evaluate the disease. So we really need to find a perfect endpoint. And that is really fundamental because we can have all the good intentions, but if we don't hit the primary endpoint, we're going to fail as a program development. So in conclusion, SwanBio is doing 2 studies at this moment. One is a natural history to collect data, to learn from the disease, and also it's a good opportunity for people to transition from the natural history study to the active Propel study. Not everybody needs to be on Signet to participate in Propel. That is important. Propel is a different organism, but all the learning experience from Signet is going to be translated to Propel and vice versa. We try to adapt and evolve, and we really appreciate the community because this will not be possible with your help. Thank you so much.
Thank you, Dr. Passalacqua. Okay, thanks again, Dr.
Thank you so much.
Passalacqua.